What does being in a coma feel like from the inside? Is it a black screen, a very long sleep, or a dream? If weeks pass, do they feel like weeks or no time at all? Can a familiar voice reach you when your body cannot answer? The honest answer begins with an uncomfortable fact. We cannot directly ask someone who is currently in a coma. And after recovery, memory cannot perfectly tell us when an experience occurred. Some survivors report nothing between injury and awakening. Others remember voices, pressure, fear, floating, or elaborate dreamlike worlds. But those memories may come from sedation, delirium, or the uneven journey back, not the deepest coma itself. A coma is not one uniform inner movie. Experience probably changes with cause, depth, medication, and recovery stage. And sometimes the most scientific answer is, we genuinely do not know. Wakefulness and awareness. First, what coma actually means. Clinically, coma means profound unresponsiveness from which a person cannot be aroused. They do not reliably follow commands or make purposeful responses. They are alive. Their heart may beat, and they may breathe alone or with support. But a reflex is not proof of a felt, conscious experience. Consciousness depends on networks, not one tiny on-off button. Brainstem and deep brain systems help generate arousal, the capacity to be awake. Broad cortical networks help support awareness of a world and a self. Coma can occur when both hemispheres are severely disrupted or arousal systems fail. Head trauma, stroke, oxygen loss, infection, seizures, toxins, and metabolic crises can all do this. Doctors repeatedly examine eye opening, speech, movement, pupils, and brainstem reflexes. They use scans, blood tests, and EEG to search for the cause and complications. Repeated assessment matters because consciousness can fluctuate. It is not a perfect window into private experience. Second, coma is not ordinary sleep. Normal sleep cycles through organized stages across the night. A sleeping person can usually be awakened by a loud sound or a shake. A person in coma cannot be awakened that way. Coma reflects major disruption or suppression of consciousness systems. That makes the phrase dreaming in a coma surprisingly tricky. Deep coma is not simply an extra deep REM stage. Yet recovered ICU patients do report dreams and unreal experiences. Common remembered sensations include thirst, cold, discomfort, and pain. A monitor alarm might become a telephone, a siren, or a helicopter. ICU delirium can produce confusion, hallucinations, paranoia, and fragmented memory. Sedatives and pain medicines can also change perception and memory. A so-called medically induced coma is usually deep, controlled sedation. It is not identical to coma caused directly by brain injury. Clinicians use deep sedation for specific medical reasons, often alongside ventilation. Many sedatives make new memory formation difficult. That can leave a blank even if some sensations briefly reach the brain. Third, memory is not a recording. We often imagine memory as a camera saved continuously in the head. An experience must be attended to, encoded, stabilized, and later retrieved. Memory-forming networks may be suppressed by injury, stress, or medication. Later, the brain must reconstruct a story from incomplete pieces. Therefore, I remember nothing does not prove there was absolutely no experience. The experience may never have been stored. Likewise, a remembered dream cannot be precisely stamped deep coma, day 4. A family member's sentence may later appear inside a dream narrative. For many survivors, the gap feels instantaneous. That is different from experiencing darkness for several weeks. It is more like no retrievable interval at all. But anesthesia, sedation, sleep, and coma remain biologically distinct states. Fourth, can someone hear you? Sound can activate parts of the auditory pathway without conscious hearing. Understanding a sentence requires much more coordinated processing. EEG studies sometimes detect responses to a patient's own name, but a brain response is not guaranteed conscious comprehension. The safest human lesson is simple: speak respectfully. Use a calm voice, identify yourself, and explain what is happening. Do not promise that every word is consciously heard. Follow the care team's guidance for touch, sound, and visiting. Most importantly, lack of movement should never erase dignity. Fifth, hidden consciousness. At the bedside, clinicians ask for a hand squeeze or a movement. That requires hearing, understanding, deciding, planning, and moving. If any link breaks, the answer may remain invisible. Researchers can instead ask a person to imagine an action during fMRI or EEG. A matching brain pattern can show command following without muscle movement. This is called cognitive motor dissociation. In a 2024 multi-center study, researchers assessed 353 people with disorders of consciousness. Among 241 without visible command following, 25% showed task responses on fMRI or EEG. It came from a convenient sample at specialized centers, not every coma patient everywhere. The group mixed coma, unresponsive wakefulness, and minimally conscious state minus. The tests do not read free-form thoughts or dreams. They can also miss conscious people who cannot sustain attention or understand the task. Brain imaging and EEG can add evidence when behavior is ambiguous. Unresponsiveness is evidence, but not perfect proof of unawareness. Sixth, the states people confuse. After coma, some people enter unresponsive wakefulness syndrome. Yet bedside testing finds no reproducible sign of awareness. In a minimally conscious state, small but definite signs appear inconsistently. A person might track a face, reach appropriately, or follow a command sometimes. Locked-in syndrome is radically different. The person is conscious but severely paralyzed, often communicating with eye movement. Brain death is also not coma. It is death, diagnosed by strict neurological criteria after reversible causes are excluded. Coma outcomes vary widely with cause, severity, duration, age, and complications. Coma usually lasts days to weeks, not years like movies suggest. Real recovery may be slow, uneven, confused, and physically exhausting. Prognosis belongs with the treating specialists, not an online timeline. Seventh, so what might it feel like? At the deepest end, there may be no reportable experience and no sense of elapsed time. With partial or returning processing, sensations may be fragmented and disconnected. During sedation or delirium, reality may merge with vivid, sometimes frightening dreams. The body may contribute thirst, cold, pressure, breathlessness, or pain. Awakening may begin as brief islands of clarity inside confusion. Another person may remember absolutely nothing. The best answer is therefore layered, not cinematic. First, coma means closed eyes and profound unresponsiveness, not ordinary sleep. Second, missing memory is not proof that every moment contained no experience. Third, ICU dreams may come from sedation, delirium, illness, or emerging consciousness. Fourth, sounds can reach the brain without proving conscious understanding. Fifth, modern testing sometimes finds command following hidden behind an unresponsive body. Finally, the honest conclusion: possibly nothing retrievable, possibly fragments, possibly a dreamlike confusion during the edges. It depends on the person and on which state, cause, and moment we mean. But private experience remains the hardest measurement of all. That uncertainty is not a failure of compassion. It is a reason for more of it. Speak as if dignity is present, even when a response is absent. Sometimes the doorway to consciousness is closed. Sometimes it is hidden. Our job is to keep checking and to knock gently.